Hello everyone, and welcome to another TP Recap episode. My name is Ibrahim Omar, and I'm a final year medical student, and I'm also a CP Solvers member. Today, I'm joined by three of my friends, Khashayar, Vinny, and Umayma, who would each present a TP recap on a prior CP Solvers VMR episode that we've had before. Starting out, we're going to have Vinny. So, Vinny, please introduce yourself to the audience and share your screen with everyone.
Hi everybody, I'm Vini. I'm a medical student from Brazil, and I'm very excited to show you guys a couple of points that I learned with the episode. Yeah. Yeah, so the case occurred on August 23rd, and the case presenter was Kerala, and was discussed by Ravi and Reza. And the first allocat, we had a 48-year-old female that is brought to the ED by ambulance with malaise and recurrent nausea and vomiting for 2 weeks. Her vitals was initially normal, and review of systems reveals no abdominal pain, fever, chills, or chest pain. And to begin, let's begin with some initial pertinent labs. The hemoglobin is 16, chemistry sodium of 137, potassium of 3.3, chloride of 112, pH of 7.14, PCO2 of 23, anion gap of 20, glucose of 236, creatinine of 2, AST of 402, ALT of 730, alkaline phosphatase of 637, the total bilirubin of 1.9, lipase of 363, A1C of 10.3, beta hydroxybutyrate elevated as 4.8. Urinalysis reveals the presence of ketones and more than 1,000 of glucose. Later, a couple of days later, the patient developed a liver function test of more than 1,000. And now begin the first question that we need to take into consideration, if this is a intrahepatic, posthepatic, or prehepatic cause. And we'll see that there is not a wide range of differential diagnosis that shows a wide variety that shows a large and rapid increase in the liver function tests. And when we see about the extrahepatic causes that can cause this significant rise, the cholestasis and gallstones that impacting the bile duct could present as that, but we'll follow on. So if you are on call in the ER and this patient comes to you, how do you proceed? I just put this question beforehand, and before we continue the case, because well, besides the vitals of the patient, it is stable, you need to take in action right away with the laboratory that you have right now. So you replete the extracellular fluid and volume deficits, or you replete the phosphate and bicarbonate deficits. You replete the potassium deficits, will give insulin, or you will give sodium bicarbonate. So for the sake of time, I'll just show you the answer. And the answer is replete extracellular fluid and volume deficits, and I'll explain it in a couple of seconds. So to continue, the patient reveals a past medical history of a 20-year history of diabetes treated with insulin, and she's using Lantus 24 units and atorvastatin. And here comes the second question, that is, why? So with that scenario in mind, we can definitely see that the patient is insulinopenic. But why the patient is insulinopenic? This is a matter of about education, that the patient doesn't know how to take the insulin. Well, I doubt it, because there's a 20-year history of diabetes. Or she's not complaining with her medications. There is a reason why she's not taking it. So we'll see that. So continue her vitals. And the patient is initially afebrile with a heart rate of 119, with a blood pressure of 163/91, and a respiratory rate of 20. Physical exam reveals icteric sclera and abdomen is distended due to percussion with fluid wave, and narrow reveals no hysterexis, no signs of encephalopathy, and extremities with the presence of bilateral 2+ edema. And I just put the narrow here as a pertinent negative because this is important when we try to differentiate about causes of cirrhosis. And we'll see, because cirrhosis is a more chronic thing, more chronic issue, and it won't occur concomitantly with such significant high elevation of liver function tests. And we'll, in the microscopy, we won't see any like fibrotic issue right now. And the same thing works for hemodialysis and a rapid rise in creatinine. If you see a rapid rise in creatinine, you can definitely think this is an acute problem. This is not a chronic one. If this is the patient with chronic kidney disease does not have like a creatinine of 15. So let's continue. 2 days later, the patient developed platelets of 82,000, INR of 1.7, a creatinine of 6.8, liver function test now that is more increased with more than 1,600, lipase of more than 7,000, ferritin of more than 13,000, a bicarbonate that is very low, an anion gap of 18, and serum osmolarity of 302, and a pH of 7.2. I just need to call your attention to the bicarbonate because we need to differentiate the metabolic acidosis and about the calculation of the anion gap. But related to the bicarbonate, there are some situations when the bicarbonate is very low, and you can differentiate when you have acidosis or diabetic ketoacidosis. When the diabetes will have like the bicarbonate that is low, and on the contrary, the bicarbonate will be almost normal. So let's continue. The liver function test declined after dialysis, and the image, the patient reveals an ascites with perfusion. She was submitted an extensive workup, autoimmune workup, infectious workup, and she didn't have any apparent cause at a first glance. So with all that scenario in mind, we can conclude that the patient has a diabetic ketoacidosis that was maybe secondary to an ischemia or pancreatitis, and this is also related to a multi-organ failure. So I'll just briefly comment about the DKA and the HHS, and let's begin with the definition. The definition of DKA is based on a triad that is hyperglycemia, based on a blood glucose of more than 250, ketosis and acidosis, and the arterial pH should be less than 7.3, the serum bicarbonate less than 15, and there should be the presence of ketonuria or ketonemia, being the ketonemia the presence of ketones in the blood. On the contrary, the HHS definition, you have a severe hyperglycemia with more than 600. The pH is not so low. You can have a pH that is almost on the limit of normal. The bicarbonate here that is the topic that I was talking about 2 slides ago. It is you have a bicarbonate that is mildly low or normal, and mild, minimal, or absent urine ketones. So continuing, we need to explain briefly about the causes of diabetic ketoacidosis, and there is a wide variety of causes, and we divided them into a couple of budgets. So we need to divide in infections, insulin issues such as discontinuation or inadequate use of insulin, some major medical events such as myocardial infarction, cerebral vascular accident, sepsis, or pancreatitis, and also medications and substances such as cocaine. And one couple of things that you need to proceed is some laboratory calculations. And the first one that you will calculate when you have a metabolic acidosis is the anion gap, that is the sodium minus the chloride minus the bicarbonate. And you will differentiate in causes of high anion gap metabolic acidosis and non-gap metabolic acidosis. Then you will proceed with the corrected sodium calculation. So if you have a patient with a glucose of 600 and a sodium of 130, due to the normal range of glucose being 100, you can conclude that the blood glucose of your patient is 5 times greater than higher than the normal glucose. And for each 100 of elevation, milligrams of glucose elevation, you need to add 2 max of sodium. So 5 times 2 will be equal 10, and you need to add this 10 to the sodium that you measured initially. So 130 plus 10 will be 140. The corrected sodium calculation is 140. You also need to take into account the Winter's formula that will calculate the expected PCO2 correction when you have a metabolic acidosis, and the delta-delta ratio. For the sake of time, I won't explore the delta-delta ratio, but you need to take into account if this is very decreased at less than 1, and if it is very increased as more than 2. If it is more than 2, you need to understand that the anion gap is increasing more rapidly than the fall in the bicarbonate, and then you will make the clinical correlations to investigate it. Besides, there is also the role of albumin in the anion gap, and the albumin is the major negative anion in the intravascular fluid. And the conclusion is if you have a low albumin, you have a lower anion gap, so you'll have a false lower anion gap. And then you need to correct the measurement, and the correction is made by this formula. So the correct anion gap is equal to the measured anion gap plus 2.5 times and 4 minus the albumin. So you will have the corrected anion gap when you put the actual value that you measure the albumin. So talking about the correlation of DKA and acute pancreatitis, this is a diagnosed challenge because liver function tests are in a big part of time different, and you can have a elevated liver function tests that is not related to the pancreatitis and vice versa. So this is a diagnosed challenge to relate the DKA and the acute pancreatitis and what comes first. So the clinical presentation will occur with polyuria, polydipsia, weight loss, and signs of volume depletion. So you need to evaluate the skin, the mucosa, the axilla, and outer parts to see if there is any signs of volume depletion. Nausea, vomiting, abdominal pain, hyperventilation, obtundation, seizures, and coma. Then following, you proceed with the management. You need to take into account the vital signs. So if the patient is hemodynamically unstable, you will proceed with the ACLS, airway, breath, and circulation, and everything. And if the patient is stable, you can proceed with the labs to evaluate the volume status, proceed with stabilization, and determine the underlying cause. You can have cardiac ischemic issues and pancreatitis, so there's a lot of issues. About the management, I can talk during hours about that, and this is a very difficult and profound topic, but you need to take into account that you need first replete water deficit that will, for a normal average person, weight person, you will proceed with 1.5 to 2 liters of normal saline. Then you take into consideration the level of the bicarbonate. If it is less than 3.3, between the 3.3 or to 3.5.3, or if it is greater than that, and we'll proceed accordingly to it. And finally, you replace the insulin, and then you need to monitor. To do the monitoring, you need to monitor the glucose every hour. You need to take to calculate the effective plasma osmolarity that I put it in the formula for you guys. And this is very important, mainly in the H8S, because you need to take into account that the H8S will be resolved when the plasma osmolarity is less than 315. You can also proceed with the calculation of and the analysis of the VBG, and to see if the beta hydroxybutyrate levels are at a normal level. So the resolution, it is when the anion gap is less than 12, the patient is able to eat, and as I said, the plasma osmolarity is less than 315. So just a few couple take-home points you need to take. One of the most important things that will contribute to your clinical reasoning is the delta ratio interpretation, the fluid and electrolyte management, a very scary complication that is cerebral edema that has a mortality of 20, ranging between 20 and 40%. And you also need to account you also need to proceed and investigate about the patient education. So that's all. Thank you. These are my references.
Thank you, Vinny, for this amazing presentation. And I hope that you're aware of the chat and how everyone is hyping you up there. So with that, we're going to move on to our next presentation for the day, which is with Umayma. Umayma, please introduce yourself to the audience and feel free to share your screen. The stage is yours.
Thank you, Ibrahim. Hi, everyone, and a wonderful presentation, Vini. My name is Umayma. I'm a medical graduate from Morocco, an internal medicine residency applicant. I'm very happy to be here, and I will be presenting a case that was presented on August 22nd by Mina Hill. She's here with us. Hi, Mina Hill. And it was beautifully discussed by Rabi and Ethan. For those of you who did not have the chance to attend that VMR, here is a problem representation that sums up what this patient had. Our patient is an 82-year-old male with a background of hypertension, COPD, CAD, CKD, and BPH. He presented with acute symptoms of fever, dyspnea, hemoptysis, and epistaxis that started 2 months ago. He reports 15-pack year smoking history, but he stopped 10 years ago, and he had recent exposure to TB. As we can see, we have a lot going on in this patient. So we will start with the foreground and one of the leading chief concerns that he had, and that is dyspnea. Dyspnea has a very broad differential, and we can only make little progress from this chief complaint alone. As we can see on this CP solver schema, the differentials are very different. We can have cardiovascular causes, pulmonary causes, neuromuscular causes, hematological causes, and even when we add the fever to have the inflammatory signature, we will still not be able to narrow it further down. However, we have another chief complaint in this patient that if we add it, we will have a very limited or very specific buckets. Rabi beautifully said during that presentation that the majority of patients who have dyspnea don't have hemoptysis, and the opposite is also true. People who have hemoptysis often don't have dyspnea. So when we Venn diagram both these chief complaints, we will have two very specific buckets, which are parenchymal causes and vascular causes. So we have to ask ourselves next, where did this problem start? Was it at the parenchymal level, at the alveoli, for example? Is it a tumor? Is it tuberculoma? And then it eroded into the vessel? Or was it a vascular problem that then eroded into the alveoli and gave us hemoptysis? Before we dig deeper into this problem, I would like to go off on a little tangent to discuss something that is hemoptysis mimics. In clinical practice, the first thing, of course, is to prioritize management to see if the patient is hemodynamically stable and sees the airway, breathing, and circulation. But if we don't have like any urgency to act on the hemoptysis right away, we first should ask ourselves, is it really the lung? Because the blood can originate from the nose, the upper airway, or the GI tract, and can be confused for hemoptysis. And the second thing is it really blood? Because we have in some bacterial infections like Serratia and Klebsiella, we have red tinged sputum that can be falsely thought of as blood, or in some occupations like glass centers who have iron oxide that can mimic blood in the lungs. So back from our little tangent, let's go back to our patient. Our patient also has hemoptysis. So when we add another Venn diagram for the epistaxis, we will further narrow it down to two main buckets: space-occupying lesions and the diffuse vascular pathology. So this patient can also have something else. Like he can probably have just epistaxis that went down to the lung and caused both hemoptysis or dyspnea. But let's focus on these two buckets: space-occupying lesion, like a tumor that's both on the upper and lower airway, or diffuse vascular pathology, like vasculitis, for example. So now that we discussed the foreground, let's go back to the background of our patient. We can see here that he has COPD, CAD, CKD, and a lot of past medical history. So we should also keep that in mind in the physical exam. This patient can also easily have decompensated heart failure or pulmonary hypertension that can also cause hemoptysis and dyspnea. So let's keep this also at the back of our minds. Concerning the physical exam, the two main findings that we saw were the SpO2 of 88% and fine inspiratory crackles. The EKG also found biphasic P waves, bilateral atrial hypertrophy, and ischemic changes in V2. So the EKG does look alarming, but let's keep in mind that he also has CAD. We don't have a baseline EKG, and we don't know whether when these changes happened. The other reassuring part is the fact that these symptoms started 2 months ago. So we don't have to further investigate the EKG right now and steer away from the center of gravity, which are the lungs. So we will zoom out and focus on the lungs, which so far are the center of gravity of our case. Concerning the labs, everything else was normal. The troponin was normal. The chemistry panel was normal, except for the creatinine, which was 3.3, and LDH of 331, and the PTH of 171. So we also have in this patient who has ENT involvement, lung involvement. We also have kidney involvement. The PTH that is elevated is also a marker of probably the chronicity of this underlying CKD. So with all of these data, we ordered a CT scan that showed septal thickening, reticular pattern, honeycomb appearance, and atelectasis. We also had negative C-ANCA and positive P-ANCA, and the DX that we retained was granulomatosis with polyangiitis. We will talk about GPA now, but before we move forward, can you put in the chat what other vasculitis do you think of when I mentioned this patient's presentation, especially what is in the slide here? With the renal involvement, the ENT involvement, lung involvement, which vasculitis do you think of? We will go back to this question later, but now let's discuss GPA. So GPA is part of the ANCA-associated vasculitides. The main four categories are GPA, of course, microscopic polyangiitis, renal-limited vasculitis, and eosinophilic granulomatosis with polyangiitis. These conditions are linked by their ANCA profile. They are often, not exclusively, but often ANCA positive, and they primarily affect small arteries. They also share the same kidney or renal histological signatures, and they also share the POSI immunity. So GPA can affect any blood vessel, any small blood vessel in the whole body, but we mainly see upper and lower tract involvements and kidney involvements, but we can also see nerve involvement, abdominal organ involvement, and the symptoms are often non-specific, which really delay diagnosis, and patients can be falsely diagnosed with infections or other inflammatory or autoimmune diseases. We will have ENT involvement, but does not only present with epistaxis. Sometimes the patient will present with crusty nose, cough, rhinosinusitis, sometimes with hearing loss and recurrent otitis media, so be aware of mimics. For kidney involvement, we have things like hematuria, proteinuria, and getting urine sediment is very important. We might also have purpuric lesions and mononeuropathy. Sometimes patients with GPA can present with foot or wrist drop. And of course, granulomatous inflammation. We should try our best to get tissue and see those actual granulomas. And in these patients and in this specific vasculitis, we often have, they are often C-ANCA positive, but not exclusively C-ANCA positive. Like this patient, he had, it was P-ANCA positive. Now back to the question that I asked you earlier. The answer is microscopic polyangiitis. GPA and MPA have so much in common. They are both ANCA-associated. They both attack small vessels. And in both, we have upper and lower respiratory tract involvement and kidney involvement. The main difference is the tissue. In GPI, we have granulomatous inflammation, while it is absent in MPA. GPA has C-ANCA markers, while in MPA we have P-ANCA. Of course, there are exceptions to this rule. And GPA has a higher risk of relapse, while MPA does not have that much of a risk. And in MPA, we also have ILDs, which are not often present in GPA. So the answer was to my question earlier was MPA. And to figure out both, we need biopsy, we need the tissue. That was all for me. Thank you so much. And the floor is yours, Ibrahim.
Thank you, Umayma, for this wonderful presentation. Just like I have told Vinny, I hope you're aware of the chat because once again, everyone is truly hyping up your presentation. So thank you so much for your delivery and for all of the search that you've done to deliver this amazing presentation to us today. And so now we're going to be moving to our last presentation, last but not least, for the day, with my friend Khashayar. Khashayar, please introduce yourself to the audience and feel free to share your screen.
Hi everyone, I'm Khashayar, medical student from Iran and one of the CP Solvers Academy members. And let's just start the presentation. Can you guys see my screen now?
Yeah, we can see your screen.
Let's start.
Yes.
So I'm going to be going over our diagnostic testing and screening protocols for tuberculosis based on a case we had this month, which was aptly discussed by Yusuf and Rabi. The patient was a 51-year-old male who presented with a psychotic episode. He was out of regular care for several years with fluctuating mental status and physical examination being relatively normal. We moved on to testing. Testing came back with HIV positive, but with syphilis negative, and a sputum TB test of negative. Then later workup moved on to show leptomeningeal involvement in CT, and finally we arrived at the final diagnosis using a lateral flow LAM testing, which came back positive for TB. Now we have many tools available for us for diagnosis of TB, but they're not effective in all situations. And I used this case as an opportunity to discuss all of the tools that we have at our disposal, which are particularly important in cases of HIV-related TB, because they may be confusing. Also, it is important to know that non-TB mycobacterial infections and TB share diagnostic tools to an extent. They have cross-reactivity in some cases, and evidence is suggesting that many cases of relapse, especially in high-burden environments, are due to non-TB mycobacterial infections that go unrecognized because they share similarities in testing for TB. We just treat for the TB, and many of the relapse cases are because of these infections. So we have to be aware of them and know our tools. But before I go in detail for these tools, I just want to remind everyone and give you the take-home point here right now that you have to study your local guidelines because TB is a disease that is highly dependent on the local health system and highly relies on it. Knowing your local diagnostic and treatment guidelines by heart will help your patients the most. This is due to availability of diagnostic tools in different regions, epidemiology of different regions, and most importantly, WHO recommends a daily supervised treatment regimen for TB. And because of that, TB in both diagnosis and treatment is highly involved with the local health infrastructure. And because of that, it's really important to know our local guidelines. With that reminder, let's go and see how do we diagnose TB, the great masquerader. I'm going to go over screening and definitive diagnostics. Let's first start with screening for TB. When we're screening for TB, we have to answer two questions. Which populations warrant a screening, and what diagnostic tools should be used for screening? In case of what populations should we screen, I have to remind everyone that a general screening protocol is not advised greatly by the WHO except in certain populations, and overall there's a weak certainty of evidence for general screening protocols, except for, again, some populations, some specific populations. We can group these populations to two groups: individuals at risk of new infections and individuals at risk of TB reactivation. Individuals at risk of new infection are those with close contact with TB and patients who have a structural risk factors for getting TB. Close contact with TB is especially important in children under 5 years old, but we have to note that the definition of close contact matters. It can change from situation by situation, and you have to decide what counts as a close contact there. Again, local guidelines can help here. What do we mean by structural risk factors? There are two general groups. One is the groups that have limited contact with health system, and because of that, they're at higher risk for getting TB, particularly homeless communities, poor communities, communities in remote or isolated areas. Generally, TB and mycobacterial infections to a greater extent are known as diseases of poverty because of this. Structural risk factors can make people more prone to catching TB. Another group here are healthcare workers with high occupational exposure. Again, this doesn't consist of all healthcare workers, but mostly is concerned with healthcare workers who are at high occupational exposure. For individuals at risk of reactivation, a particularly important group for us is HIV patients. The only group that WHO has moderate strengths of evidence in its recommendation for systemic screening protocols, but we can extend this recommendation to generally immunocompromised patients, especially if we live in a community with high risk of TB contact. Don't forget the immunocompromised states that we might usually forget, like DM or CKD. Another particular important group here are patients at risk of silicosis. Particularly important here are minors. Now that we've discussed the populations that can most benefit from TB screening, we need to discuss what choices we have for screening tools. Generally, 4 tools are available for us for screening: TSC testing, gene expert testing, chest X-rays, and IGRA. The main recommendation, first-line recommendation by WHO is gene expert testing because it provides us with greatly specific and sensitive tests, and it allows us to test for drug resistance, but this is not available everywhere. So again, go back to your local guidelines. Let's go over to tools. TSC testing was developed in 1941 and is the most widely screening test used for TB worldwide. It measures the response to antigenic stimulation by T cells that reside in the skin rather than those that are in the circulation. The test is usually done by injecting PPD under the skin and measuring the induration after 48 hours to 72 hours. Again, I have to remind everyone here, measure the induration, not erythema. This is a very common mistake in interpretation of the case. Let's see how do we interpret this. A more than 5 millimeter increase in induration for patient at high risk is counted as a positive test. I have to remind everyone that HIV patients and generally immunocompromised patients don't behave as expected for these tests. So in case of an HIV patient with a close contact, even a less than 5 millimeter increase, it counts as a positive test. Another use that this test has is for serial testing, especially in cases of monitoring a patient response. So in case of serial testing, induration should be more than 10 millimeters, and it should be accompanied by more than 6 millimeter increase compared to the previous TST to count as a positive test. Cutoffs higher than the usual 5 millimeters can be used for populations who are at lower risk, but sensitivity and specificity both drops by using higher cutoff values. Another thing to consider here are false negatives and false positives for this test. False negatives can be caused by technical factors like mishandling of the equipment or biologic factors like immunocompromised state of the patient. False positive, which are particularly important to us, are for mainly previous TSC and TB infection. If a patient has a documented positive TSD, there is no reason for serialized TSC testing or another TSC at any other point in their life. Same goes for a documented TB infection. But if you have an undocumented TSC, you can repeat the test using the serialized protocol I mentioned before to make it documented and make sure that it really is there. Another cause of false positive, which is often mentioned but misunderstood, is BCG vaccination. One thing to consider here is that if BCG vaccine is administered in the first year of life, it's not relevant after the patient is 10 years old. You don't have to consider it for a false positive. But if it is administered later in life, it can mess with your results. So just keep that in mind. Another important test here that is highly used everywhere is IGRA testing. It is an interferon gamma release assay. It measures the response of circulating memory T cells as opposed to the skin cells we had before for TSD. This test only detects presence of infection, and it cannot distinguish active disease with previous infection. The test can come back as negative, positive, or borderline invalid or indeterminate. We had another case this month which came back as indeterminate. I highly recommend you check it out. It was a really interesting case. If the test comes back negative, we should do repeat testing if the patient is high risk of infection. If it comes back as positive, we should proceed in some cases with treatment directly. In some cases, we should go for diagnostic testing. Again, I refer you to your local guidelines. Sometimes, like here in Iran, you don't even need any screening test for starting treatment. You can just start based on high clinical suspicion. In case it comes back as borderline invalid or indeterminate, you should again repeat the test, but keep that in mind that there is higher risk for indeterminate results in individuals with systemic conditions like pregnancy, HIV, or immunocompromised state. Now that we've gone over the screening test, let's go see how we can definitively diagnose TB. This is particularly important because sometimes our screening tests don't behave as expected, especially in immunocompromised patients. And these tests, some of them allow for antibiotic resistance testing, which is extremely helpful in case of TB. Our first line definitive diagnostic test in many places is AFP smear testing. It is mostly relevant in the context of pulmonary TB, but it can be used in other cases. Smears of specimen collected from pleural fluid, urine, or gastric lavage have lower lower sensitivity. It has low sensitivity because it is equipment dependent, it is operator dependent, but it is highly specific. This is, again, especially important in HIV patients. One thing to consider here is that it is important how the sputum is produced. Usually you need 3 specimens. Our protocol here is that you get one specimen when you meet the patient, another one in the morning the day after, and another one when the patient comes back to return the sputums. Again, go back to your local protocols for more accurate representation. Our gold standard for TB diagnostic testing is mycobacterial culture. There are 2 main cultures used for this case, solid culture versus liquid media. This provides methods for drug susceptibility testing and speciation, which is important in differentiating between TB and non-TB infections. It comes back faster in liquid media. We should check it in 2 to 3 days interval in liquid versus twice weekly in solid. but both should be used at the same time because some species and subspecies grow differently in different media. So just keep that in mind. Both should be used usually at the same time. Any one of them that comes back positive first gives us the diagnosis. You need at least 8 weeks before calling it off as a negative result. But when it comes back negative, you can count on the negative result. Another method for definitive diagnostic testing are nucleic acid amplification methods. The most popular one and the one recommended by WHO is the gene expert method. It is the first for both screening and definitive diagnostic in WHO guidelines. It is relatively cheap, extremely fast, but availability and adaptation is still a problem for this methods. It is highly specific and sensitive, and it provides methods for speciation and drug susceptibility testing. In all of the cases I mentioned here, tissue is the issue. Where and what specimen you send for diagnostic, for culture, for smear testing, for a nucleic acid amplification matters in every case. Depending on what you send, you get different specificity and sensitivity. Finally, a test I want to mention that is extremely important in HIV patient, and it is the test that was used for our final diagnosis in the case that I mentioned at first, is the lipto-arabic testing, also known as lateral flow LAM. It tests for a glycolipid in the membrane of Mycobacterium species that is detected in the urine. The test detects the antigen in the urine. It has low sensitivity, but it is particularly specific in HIV patient, and we can increase both specificity and sensitivity by combining it with gene expert methods. It has cross-activity with non-TB mycobacteria, so we have to keep that in mind. Thank you for your time, and I hope you have enjoyed this presentation.
So thank you, Khashayar, for this amazing presentation. I truly learned a lot from it, despite how many VMRs we've had on TB before. Also, thank you so much for sharing all of these pearls with us. And I wanted to thank the audience for joining us today on our TP recap episode. And we look forward to seeing you all tomorrow, hopefully on our VMR with Stefan Zavin, happening at 1 p.m. Eastern Time. So goodbye, everyone, and I hope you have a wonderful rest of your day.